I'm going to get started. I'm Molly Regelmann. I'm one of the pediatric endocrinologists at the Children's Hospital at Montefiore in the Bronx. And I want to thank the organizers for ALD Connect for the invitation to come and speak to everyone a little bit about endocrine concerns related to adrenoleukodystrophy. Before I get started too much today, I would like to just poll the audience so I have a sense of who's out there. And they'll put up a polling question for everyone. If everyone can just answer for me, if it's possible, what their backgrounds are so that I get a picture of who's out there. It would be helpful. Thank you. And while the polling's going on, I'm going to just go over. So for today, what I'm going to try to do is review what normal adrenal pathology is. I wrote down pathology, but normal adrenal pathophysiology is. I will go over the adrenal pathophysiology and clinical manifestations related to ALD. I will also discuss adrenal insufficiency screening guidelines, and then I'm going to address treatment of adrenal insufficiency. And at the end of the talk, I'm going to spend a bit of time talking about androgen insufficiency and testicular dysfunction, which are also concerns with ALD. All right. And I want to thank everyone for answering the polls. I see there are a few more people still answering, so I'll keep it going for a few more minutes just so I have a sense, but it looks like we have a mix of people in the audience, which is great. So I'm going to try to address everything for everyone, and I will also be, at the end of the day, I will be on one of the panels, so I'll be happy to answer questions there as well as questions at the end of the session. So normal adrenal function, let's just go over it so we're all speaking the same language. So normal adrenal function starts with just talking about what the normal axis is. So there's a center in the brain called the hypothalamus that normally during the course of the day will secrete a hormone called CRH, which turns on the pituitary gland to release ACTH. ACTH then turns on the adrenal glands to make cortisol. And when there's enough cortisol around, there's feedback up to the hypothalamus and then the pituitary to turn off. This is a naturally occurring rhythm for secretion that happens throughout the day, but during times of stress, there also are increases in ACTH and cortisol as well. And I like to show everyone what the adrenal cortex looks like. This is a cartoon characterization, but there are 3 zones to the adrenal cortex, and each zone is responsible for making different hormones. I'm primarily going to be focused in on today the glucocorticoids or cortisol, which is made in the fasciculata, but I will touch on androgens and mineralocorticoids throughout the talk as well. So I mentioned that cortisol secretion is regulated by what we call a diurnal rhythm. This is the rhythm that's regulated by sleep cycles, or circadian rhythm. And what happens is naturally you get spikes in the ACTH and cortisol that occur right around the time of waking. And the cortisol levels tend to be lowest at the onset of sleep. So at the beginning of the day, they're high, and then they naturally drop down over the course of the day. It's important to understand that this rhythm does not start to develop until around 6 to 12 months of age and can take up to 3 years to fully mature. So why is cortisol important? Cortisol is important because it conserves glucose, which is your body's fuel. And it also helps to increase the production of glucose from storage forms in the body. In stressful conditions, it also increases blood pressure And it does this by helping to increase water and sodium or salt retention. It also makes blood vessels constrict, and it also increases epinephrine, which is the stress hormone, the flight or fright hormone that helps to raise blood pressure. So what happens with ALD? I know that for the past day, everyone's been talking about very long chain fatty acids. So I'm going to skip over a lot of it, but just say that very long chain fatty acids are elevated in ALD. These very long chain fatty acids tend to accumulate in the adrenal cortex, and they preferentially go into the areas of the cortex, the fasciculata and reticularis, which are responsible for making cortisol as well as androgens. Now, they also will accumulate in the glomerulosa and cause problems with mineralocorticoid production for some boys and men with ALD. And mineralocorticoids are important for helping you hold on to salt in your body. So if you don't make mineralocorticoid well, you tend to lose salt and crave salt and can have electrolyte or salt abnormalities in the blood. So how do the very long chain fatty acids disrupt the production of cortisol? So the very long chain fatty acids get incorporated into the adrenocortical cells. They can then cause stress in those cells and cause the cells to die, basically. That's what apoptosis is. They can also get incorporated into the lipid layer of the adrenal cortex and disrupt how ACTH, the hormone that comes from the pituitary, binds to its receptor. And in that scenario, the cells get shriveled up and don't necessarily die, but they're just not responsive to the ACTH. They atrophy. And then there also is a theory that the very long chain fatty acids, because they're important for making cholesterol, and cholesterol is one of the initial, it's part of the process of making cortisol, that because there's less cholesterol theoretically around, that also leads to lower cortisol levels as well. So what ends up happening with ALD is you lose the ability to make cortisol in the adrenal glands. And because cortisol naturally will turn off ACTH and CRH production, you end up with a rise in ACTH and CRH. And so what ends up happening is you have high levels of ACTH, low levels of cortisol, and over time, you also lose the ability, there's also a loss of androgens being made. And for some men, again, you can also lose the ability to make mineralocorticoid. So what are the symptoms of adrenal insufficiency are important to understand. Why do you need it? The cortisol, as I said before, it helps with blood pressure in stressful situations, but it also helps with making sure you have enough sugar around. And when men develop or boys develop adrenal insufficiency with ALD, it tends to be a chronic condition at first, where there's fatigue. Anorexia in this case means like not hungry, not eating, weight loss, or in children, they will not gain weight appropriately. There may be complaints of intermittent abdominal pain, constipation. And then the real classic finding is this hyperpigmentation. And that develops as a result of the excess of ACTH. And hyperpigmentation can be found in certain particular areas on the skin. The creases of the palms and soles are a common location. The backs of the ears, right on the helix of the ear. Anywhere there's been a scar, gums will look very pigmented. And you can also see it darkening in the genital areas and the nipples. If there is mineralocorticoid deficiency, you will also see salt craving behaviors, this is very obvious. This will be someone who just feels like they have to add salt to everything. And really it's like dumping salt on things. When I have children who have this, they will take a pretzel, lick the pretzel, and toss the pretzel aside. They just want the salt off of the pretzel. In the acute setting, when someone is sick with adrenal insufficiency, this is life-threatening. And in that situation, you can have nausea, vomiting, severe abdominal pain. Kids can get dehydrated. They get hypoglycemia, means low blood sugar. Hypotension is low blood pressure. They can have altered mental status. This means that they may not act their normal self. And almost always this happens at a time where there's some other form of stress. So infection, a broken bone, anesthesia, something that usually it's a chronic condition that then gets triggered by something that causes this acute decompensation, which is life-threatening. This is just a picture of hyperpigmentation from a case report in the literature, and I just want to point out these are family members of the same ethnic background, and you can see that the skin gets very dark. Sometimes it's dark all over, but you can also see that the pigmentation in the creases is even darker, and on the knuckles, as well as the tongue and nipples for this patient. So what do we know about adrenal insufficiency? So adrenal insufficiency in ALD occurs in somewhere around 80 to 86% of boys. And then we'll go through the studies that we have, the biggest studies we have that give us these numbers. The earliest report of biochemical adrenal insufficiency is 5 weeks of age. And it's reported that adrenal insufficiency occurs in fewer than 1% of females who are heterozygous for the ABCD1 mutations. But there are very few data actually following this up long term to really know the true incidence, but we think that it's not a common finding. And the other thing that's important to understand is there's no biochemical marker to predict the onset of adrenal insufficiency, and there's no correlation with the very long chain fatty acid levels and the onset of adrenal insufficiency. So I'm going to go through the two big studies that are out there that give us information about adrenal insufficiency and ALD. The first study is from it was published 15 years ago, and it's out of Kennedy Krieger. They looked at 49 boys who were asymptomatic and had only been identified based on family history. These boys were quite young, so the average age was 4.5, and the average follow-up time was 2 years. When they did baseline blood tests on these boys, they found that almost 80% had either frankly abnormal test results or borderline abnormal test results when they did adrenal testing. And at the follow-up, at the end of the study, 86% of these boys had evidence of adrenal dysfunction. They did not routinely check for mineralocorticoid deficiency in these boys, but of those that they did test, 18 had normal or intact mineralocorticoid deficiency, which is consistent with other studies. This is just a bar graph that just is showing how many children based on age had abnormalities. So it wasn't just the older boys, it was also younger children who had either borderline or frankly abnormal levels. And the age in the first bar is 0 to 2 and then 3 to 5. So you can see this is the cream color is borderline, and the light purple color, periwinkle color, is frankly abnormal. So you can see it was really common. The other study that looks at a big population of men and boys with ALD was a combination. It was performed at neurology clinics in Boston in the Netherlands. And they had 159 men or boys enrolled in their study. It was retrospective, meaning they did not follow they did follow over time, but they went back in time to look at charts. And when they went back in time to look at the charts, 80% had adrenal insufficiency, and most had developed adrenal insufficiency during childhood or adolescence. The youngest child in their cohort with abnormalities was 7 months old. A couple of things that I think are important out of this study were 2/3 of the men were thought to be symptomatic when they were diagnosed with adrenal insufficiency, or boys, I should say. But there was a significant delay in diagnosis. So, and again, this is retrospective, but looking back in time, the delay in diagnosing adrenal insufficiency was on average about 3.5 years. And they had one man in their study who had symptoms for 21 years before it was recognized that this is what was going on. More than half of these patients were treated with mineralocorticoid therapy, but none were treated with mineralocorticoids without being treated with hydrocortisone. So everyone who was diagnosed with adrenal insufficiency had cortisol deficiency, and more than half also were thought to have mineralocorticoid deficiency, but the mineralocorticoid deficiency seemed to develop in more so in the adult population. And again, there was no correlation with very long chain fatty acids and adrenal insufficiency. And this is just a chart from their study. So the median time, meaning half of the men, or boys I should say, had adrenal insufficiency in the study by 14 years of age. But it took another couple years on average to get treated for it. The median time to developing mineralocorticoid deficiency was 56 years of age. So again, mineralocorticoid deficiency not as common, but does develop. So I'm going to stop here for just a second and we'll ask another polling question. And the next question I'm going to ask is just for those of you without adrenal insufficiency or not caring for someone with adrenal insufficiency in the audience, how many of you are aware that there are monitoring guidelines out there for checking in on adrenal insufficiency? And I'll give you a second. I'll give up to about 45 seconds to respond. So how many of you are aware that there are guidelines out there for adrenal insufficiency? All right. So I'm going to share with you. So it's good. About 2/3 of you are aware and 1/3 are not. So it's good that you're attending this talk so that we can go over it. So I always like to show the monitoring guidelines. So I think I'm the only endocrinologist speaking today. I do point out that they have all these different, this is 2012, there are all these different algorithms for what to do with cerebral ALD. And when the diagnosis is made, it just says refer to endocrinology. And there wasn't really anything in the literature for endocrine guidance from the pediatric endocrine world until a few years ago. So I like to talk about what my approach is, but my approach is similar and summarized in the Pediatric Endocrine Society guidelines or guidance for adrenal insufficiency screening. The guidance was written specifically for newborn screening, but the title says for newborn screening, but also applies for older boys and adults as well. Once ALD is confirmed as a diagnosis, my goal as an pediatric endocrinologist is to see the patient within a week's time. And the reason is exactly what I just presented to you, is that adrenal insufficiency often is not diagnosed for years. And so I want to make sure that I have identified, have gone over everything with a parent of a newborn, but also help to identify anyone in the family who needs testing, so that I make sure that we're not treating adrenal insufficiency. I do a physical exam on the baby. I look for signs and symptoms of adrenal insufficiency, which again, in an infant, in a newborn, it's very unlikely to find any signs or symptoms. In older children at diagnosis, it's not unusual. And then I counsel parents and caregivers to recognize those signs and symptoms of adrenal insufficiency at home, just like I just went over, those chronic signs of not eating well, belly pain, and the darkening of the skin. And I just want to point out, I know ALD Connect has a wonderful website, but there also are other resources out there. And I know many of the people here in the audience have probably already accessed these websites and looked at these resources, but I just always remind parents that these resources are out there for them. And then in terms of the testing guidelines, so as I mentioned, the Pediatric Endocrine Society Drug and Therapeutic Committee and Rare Diseases Committee, it's a long name. I'm a member of that committee. We worked as a group to come up with guidance that made sense for infants. But again, a lot of the recommendations can be applied to older children and men as well. The big concerns with screening with infants came up as it relates to that circadian rhythm that we mentioned before. So anyone who's had an infant at home knows that they don't sleep and they're up all night and they feed at all sorts of irregular times. And for that reason, their circadian rhythms have not yet developed. And so predicting when ACTH and cortisol will be secreted is very challenging under the age of 6 to 12 months. In addition to that, there are no reference ranges for ACTH under the age of 3. And the cortisol reference ranges have a lot of concerns in infancy, not only because of the problems with predicting when cortisol will be secreted, but also because infants in general tend to have lower cortisol levels. And also there's a binding protein for cortisol that is lower in neonates than it is in older children and adults. And I'll go through the algorithm here in just a second, but I would also just say that when to start screening and how frequently to screen is unclear. And it's still unclear. The guidelines that we published suggested that under the age of 2, that screening is done every 3 to 4 months. And the reason for doing it so frequently at that age is because it's incredibly difficult to diagnose adrenal insufficiency in children under the age of 2 just based on clinical symptoms. And so the thought is that screening more frequently, we will catch any changes that are happening. In children over the age of 2, the recommendation was to screen every 4 to 6 months because it's a little easier to recognize signs and symptoms for parents to call. My experience is that I have had newborn screening patients who have had signs early, and I've also had children who have developed adrenal insufficiency in a 4-month period of time. And so I think the reasoning for these recommendations in terms of time was based on partly my experience as well as the other members of the group's experience in the writing group. So So the approach in general is that under the age of 1, because infants have not yet developed the circadian, they have not yet developed that predictable pattern of secretion, that we measure their levels at random times or do a special stimulation test, and that after 1, we then do their measurements at 8 o'clock in the morning. So this is the algorithm that's part of those guidelines, and this, I won't go into the details of this algorithm, but I do want to make sure that you're aware that this is out there. The reference is at the bottom, and it's available to any pediatric endocrinologist or to any parent if they need to look at it, but it's definitely helpful for interpreting the test results. And I mentioned that my experience has been that I have had newborns who've had biochemical evidence of adrenal insufficiency. And this is a publication from one of my fellows and I that we published, that we did have, we have had newborns at 5 weeks, as young as 5 weeks, with biochemical evidence of adrenal insufficiency and 4.5 months of age. So it just emphasizes the need for newborn screening and urgent referral. So I'm going to now move on to treatment. And for those of you who have who are caring for someone with adrenal insufficiency, I'm going to go through a couple of extra things that I like to make sure everyone knows about. So treatment for adrenal insufficiency is the standard treatment that we have for anyone who has primary adrenal insufficiency for any reason. Hydrocortisone is the preferred medication because it mimics cortisol as well as any of the steroids. Stress dosing is given as needed, and parents and caregivers need to be trained on how to give stress dosing. And a parent or caregiver should always have access to an endocrinologist to help them with stress dosing guidelines. We do recommend monitoring for mineralocorticoid deficiency, and the guidelines suggest that once requiring hydrocortisone, plasma renin, which is, and electrolytes, which are what we use to monitor for mineralocorticoid deficiency, is measured every 6 months. And then the treatment for androgen deficiency is a little controversial, and I'll get to that in a few moments. Children need to be monitored long-term for side effects of steroids. And I always mention, particularly in the ALD audience, to be aware that other medicines can interfere with how hydrocortisone is metabolized. So very important to make sure that if medication changes are happening, that you discuss them with the endocrinologist. So I'm just putting this up. This is an action plan, and I don't know how many of you out there have action plans. If you have adrenal insufficiency, or if you have a child you're taking care of with adrenal insufficiency, it's helpful to have some sort of action plan. This is an available action plan that the Pediatric Endocrine Society has made. And again, the reference is at the bottom of the page. It's helpful. You can write out the daily dose, the sick day dose, the emergency dose, and then plans if you're having surgery. I don't have time to watch a video today, but I do think it's really important to always review how to administer Solu-Cortef. I did have a polling question, but we're running short on time, so I want to make sure we get through everything. But ideally, this is a video that you should review with any caregivers at least once a year to remind everyone how to give the emergency injectable hydrocortisone. And again, the link is within the slides for that. The other thing that's important is making sure you communicate with the local emergency rooms on how to take care of a child with adrenal insufficiency. So the Pediatric Endocrine Society also published guidelines for how to communicate with local EMS and emergency rooms. So this is a sample of an emergency room workflow algorithm. And this is something that a pediatric endocrinologist or adult endocrinologist could send to a local emergency room so that it helps them go through what the steps are if there's an emergency. And then I also recommend that everyone have an emergency letter that they can take to the emergency room and they can hand off and say, this is hand to the emergency room doctors or to EMS that says, this is what the dose of medicine is, this is how to contact my doctor to go over the rest of the steps. And I think that it's really important, if you have an emergency plan and you have stress dosing plans in place, they're highly effective and they prevent any problems from coming up. This is a paper specific for ALD that came out of Minnesota, where the anesthesiology department there and the endocrinologists have a hydrocortisone dosing plan in place. And they found that with 166 procedures, and 87% of those procedures were associated with people who had known adrenal insufficiency. They had no events related to adrenal insufficiency because they were treating everyone with hydrocortisone appropriately. I also just really want to touch very briefly on the fact that Lorenzo's oil is not thought to reverse adrenal insufficiency. There was a very small open label study that suggested maybe it slowed the progression to adrenal insufficiency. And I also mentioned that bone marrow transplants and gene therapy are not thought to be a treatment for the adrenal insufficiency either. The gene therapy, there's not data reported yet, but the bone marrow transplants, it doesn't seem like it alters the adrenal insufficiency progression. All right, and then I'm going to just briefly go over androgen deficiency and testicular dysfunction, and I want to leave a little time for questions, but I do want to point out that ALD is associated with testicular dysfunction, and that it occurs roughly in about 75% of adult men. And it's thought that the very long chain fatty acids, or not thought, they do accumulate into the testicles and disrupt the androgen receptor. And so this can impact also, can also lead to long-term concerns as well. Because if the testicles aren't making testosterone properly, you're going to have problems with bone mineral density, anemia, decreased muscle mass, decreased endurance, and sexual dysfunction. There are very few studies looking at this, and all of them are much older and go back to the 1990s, but most of them, I should say. But to summarize those studies, because I want to leave time for questions that I can see are coming up. To summarize those studies, they found that testicular dysfunction is relatively common. And it's something that, at least in the 90s, people were less comfortable talking about. And so it's really important, I think, for any of the men in the audience in particular to feel comfortable talking to your doctor about this and asking the appropriate questions. Often in the adult world, testosterone does need to be replaced. In the pediatric world, it's a very rare issue for us to have to deal with, but occasionally it does come up for us as well. All right, I'm going to stop there because I can see there's several questions and I will try to answer them as best as I can. Okay, so I'm just taking from the top, and if I don't get to all of your questions, I will keep answering afterwards because I know we only have about 5 minutes left. One of the questions is, before my son was diagnosed with adrenal insufficiency, he craved salt and lemons. He would eat the lemons like an orange. Any idea what his body was getting from the lemons that was missing? That is one I have not heard before. Salt, yes, definitely. I'm not sure with the lemons what would be getting specifically replaced, but I will say it's not unusual with adrenal insufficiency for certain things foods not to be tolerated as well. So it's possible that the lemons were providing it was an easier food to tolerate. One of the other questions was, can an adrenal crisis look like a seizure? Absolutely. Adrenal crisis, particularly in children, is associated with low blood sugars, and low blood sugars in themselves can cause a seizure. So it's not unusual that a child has a fever, especially really young children, that they have a fever, they go to the emergency room because they've had a seizure associated with that fever, and they are told by the emergency room doctors that it was a febrile seizure, which it is a fever and a seizure, but with adrenal insufficiency, it can also be due to low blood sugars at that time. The other thing is that low sodium levels, which can occur with mineralocorticoid deficiency, can also cause seizures. So definitely adrenal crisis can sometimes present with seizures. The treatment is hydrocortisone in that situation. I do have some boys who have seizures from cerebral ALD as well as adrenal insufficiency. If they are getting their hydrocortisone regularly and they've always been they aren't missing doses of hydrocortisone, I tell the parents to give the diastat, like the medicine to stop the seizure, and then draw up the hydrocortisone to give the stress dose. You usually have about 15 minutes or so to give the stress dose of hydrocortisone if you've been giving hydrocortisone consistently. The tricky part of that is someone who doesn't know they have adrenal insufficiency, that's a different story. But if you know you have adrenal insufficiency, you can you should take care of the seizure, assuming you haven't been missing hydrocortisone. If you've been missing hydrocortisone, then I would treat with hydrocortisone immediately. So I have another question. Would you suggest doing anything if ACTH is extremely low besides hydrocortisone? So usually with ALD, ACTH is elevated because you have primary adrenal insufficiency. So the adrenal glands are not making the cortisol, and then there's an elevation in the ACTH. If you're being treated for adrenal insufficiency, you're being given hydrocortisone back, usually the ACTH levels will still be a little bit elevated. If the ACTH levels are extremely low while you're on treatment with hydrocortisone, it usually means that you're getting too much of the hydrocortisone, and so usually that means a dose adjustment is needed. So when I'm monitoring my patients who are on hydrocortisone, I will measure ACTH to make sure that I'm not giving too much, because I want to make sure that they aren't getting if they get too much, that can cause problems with growth, but it can also cause abnormal weight gain, and high doses of steroids can also cause like cholesterol problems and things like that long term. Okay, I think I answered that question. I had a question. Do you see any thyroid issues for cerebral ALD kids? So there's no specific correlation with autoimmune thyroid disease and cerebral ALD that I am aware of. Autoimmune thyroid disease is a relatively common condition in general. It may be more common. I'm just seeing now also the question also said bone marrow transplant. So it may be more common after a transplant, and sometimes autoimmunity after transplant is not uncommon. I would also say, though, that thyroid hormone levels can be altered by those anti-seizure medicines that also can alter hydrocortisone dosing. So sometimes you will see anti-seizure medicines altering those levels as well. Okay, I think I may be up past my time. I'm happy to keep answering questions, but I also want to make sure everyone gets to their next session. So I'm going to type answers to the rest of the questions, if that's okay. And then I will also be in the session I will also be in the Ask the Expert session, and we'll be happy to answer questions there as well.